Yeah, we can. I'm sure, Dr. Daniel. I'm sure that Dr. Rodwin is going to call you many times to ask his own questions later. So I think let's try to.
I read all those articles that know much more than I
do. You were part of the movement.
Okay,
we have a question from Christine Lai,
let me
medical student at New York University Medical Center in her 3rd year.
Hi.
Hi, I had a question about, I guess, healthcare personnel shortages. Do you find that your clinic or other clinics need to employ nonprofits or, like, I guess, contract with them is a technical term to get more personnel?
Okay, the sound is back. So I'm going to ask Rafael to translate this into Brazilian accent.
O que ela tá perguntando é se existe uma falta de médicos no Brasil e se as estruturas, por exemplo, de hospitais públicos e hospitais privados precisam depender de organizações não governamentais para estrutura médica e que é infraestrutura de assistência médica. Se existe uma dependência, eu acho que basicamente o que ela quer saber é se existe uma dependência. I think basically what you're asking is if there's a dependency on non-profits and non-governmental institutions for the provision of.
But you were asking to contract with the SUS or to substitute for the SUS?
Just the contract with them, I guess. That's what.
To answer this, I'll have to describe a little bit the present situation of the SUS. It's very complicated. It's a very complex answer.
Yeah.
SUS is a universal system which is presently mostly based on primary health care provision. What we call the family health strategy or family health program is spread around the countries it covers presently about 120, 130 million Brazilians. Mostly the poorest, on the peripheral areas, on smaller cities and in the poor areas of main cities. This program just had the addition of 6,000 doctors from abroad because we didn't have doctors enough to cover the most extreme located areas. Either extreme in terms of geographical terms, so the most inland, the smaller cities, the country regions, let's say the rural regions, and also extreme in terms of urban violence. So we didn't have people to cover the favelas where there was most violence and so on. So they had to bring 5,000 or 6,000 doctors from abroad. The first group was basically doctors from mostly Cuba and also some other countries. The second group was already 80% Brazilians because they saw the program was working. So they had a salary which was a little bit higher. There was a huge fight with the corporation, the medical corporation, because they wanted them to make diploma correspondence, and the government didn't accept that, and so on. So this demonstrates a little bit the lack of doctors in the public system, in the primary health care system, which is a part of the SUS, of the public system. And which is now, I would say, it gained on coverage, of course, because 6,000 doctors mean about 18 million people more, so we jumped from 120 to 140 million people covered and so on. So I would say the primary health care is basically well provided and doesn't depend on any other institution. It's provided by the government, by the public health system.
Yeah.
There is also a strong private system in Brazil, which unfortunately it's called supplementary system. It should supplement or complement what the public system doesn't cover. So I'd say highly complex care or alternative care, etc., etc., or special hospitals, etc. It doesn't work like this. It's a competition instead. So the private health system is now spending more money than the public. It's about 55 to 45, the relationship. They have about 40 million clients. They are, in great part, they are funded by public money because there is a tax exemption, a fiscal renounce from the government. Did you say like this in English?
Yeah,
fiscal
yeah.
renounce.
That's exactly right.
Renunciation.
Yeah.
So if, for example, in my income tax,
Yeah.
I can deduct 100% of what I spend in health. 100%.
Including
There's
premiums. Right.
no other exemptions like this. If I go 15 times a year to a psychoanalyst that charges $100 a consultation, I will deduct the whole thing
Yeah.
from my income tax. Of course, you deduct not from the tax you owe, but you deduct from your income. So
Yes.
it's a lot of money. It's a lot of fiscal renunciation from the government to the public, to the private system. So the private system lives on fiscal exemption and also on payments, especially for 90% of the funding is basically through health insurance companies.
That's very important.
Health plan companies.
I think that's a key
So,
thing. That's a key. That was a good thing to mention. This
Yes.
taxes thing, because the SUS is funded by taxes. But if you're paying, if you choose to go to private and you get to deduct what you spend on your taxes, you're also taking money from the public, from the public system. So you're actually supporting the private system with this mechanism. So it was a very good thing to mention.
This is exactly the same thing we have in the United States with the tax deductibility of employer premiums for taxation, from taxation, which explains the strength and survival of the private employer-based insurance system.
Yeah.
Without those exemptions, that private system would not exist.
Yeah.
We will survive.
I think
So-
we have a question.
Now we're getting some questions. So just one question, because mine is related directly to this, and then I take the prerogative. Because I read a very interesting article, probably by a colleague of yours, I don't know her first name, Cohen, C-O-H-N, Anna maybe, who published this in Social Medicine. The title of it was Brazilian Health Reform, Victory over the Neoliberal Model. So my question to you, based on what you've said, was it a true victory, or has that victory given in a little bit to the return of the neoliberal model?
We're at least even. There's no victory.
Okay.
Because what's going on in Brazil is very similar to what goes on in education and health.
Mhm.
There's a progressive loss of prestige of the public system. So what happened in the last 30, 40 years is that the medium class and the high class does not count on the public health system, does not count at all, except for a few islands of excellence. For example, they use what is mandatory. They use for transplantation. A rich guy has to be on the line for transplantation because it's a unique line. Just like, Frank, your president, Frank Underwood. He also had to wait on the line for field liver transplantation. The professor is not understanding that, but you do.
It's the show.
It's the house
That's a
of
card.
cards.
It's a television show.
Oh, right.
HBO.
No.
HBO.
No, Netflix.
Netflix. Kevin Spacey.
For example, if you have HIV or if you have chemotherapy, very expensive medicines, they go to the public hospital just to get the medicine. So HIV care is very high quality in Brazil, so they also get the medicine from the health units, but they go to a private doctor.
Yeah.
So nobody trusts the health system. And there's a very strong lobby of the private sector to undermine the image of the health system. This is how, this is maybe the most effective marketing agenda of the private health plan, health insurance companies. It's undermine this prestige. Every time the system appears on the television is to show public emergency sectors in which women are giving birth on sinks and people are abandoned in the corridors, etc., etc. So the tragedy, which is true in cases, but it's not only like that. TUS has excellent, very, very good quality services in many parts of the country, and it's undermined by low funding, low prestige, marketing against, and also low quality management. So what we see today is that instead of a universal health system, we are getting more and more a public health system directed to the poor, and a
I think he was going to say a private system directed to the rich.
So maybe
It's
probably
maybe,
his
yeah.
internet. Yes,
Oh.
his international.
This is your video that's showing me.
He's connecting. it, yeah.
Well, I didn't think he'd be so long, so let's let whoever is this.
so what's my daughter, so I have to ask.
So I think we had
I need to know what was the problem. She doesn't call me very often.
so we have. I think you're not seeing us, but
I can see you now. I don't
let me
see
turn.
you.
Okay, now I'm turning the camera on. So we have a
We have a
question.
fellow,
I think he had a question first. Yeah.
Sure.
So I see a lot of similarities between the Brazilian system to the Russian healthcare system.
Can you hear it? Can you hear him or?
Introduce yourself. We have our
He's frozen.
Oh, it's frozen again.
It's frozen.
a Russian student who became an American and is working here now.
I think he's not.
He's frozen.
Oh, wait.
Yeah, he's not.
Emma's calling him again.
A pretty good long run there. It's like
Yeah, the private system cut him out.
Skype never works, like, you know, like,
He
well,
when
he
it's
knows a
supposed-
lot
this is
about.
very
He
good.
knows a lot about this for sure. I mean, he's talking about
Yeah.
some really interesting details that nobody mentions. I mean, this taxes
Yeah.
thing.
Yeah.
It's
Yeah.
really impressive.
Yeah.
It's really relevant. And
I just had a question like to ask.
yeah.
The way he said, like, some of the public hospitals, they face this kind of situation where the childbirth is having
Yeah.
such a weird situation.
Not all of them, but
So
some.
but then he said like it's true. I thought it's not true, but
It is true. I mean, it's also like when remember I told the story about the girl who died of the orange juice.
Sure.
It's
Yeah.
like, and Professor Rodwin said, well, it's like one story. So yeah, of course, they always show the one stories.
Yeah,
Like,
yeah, yeah.
I think
But
one-
my question is like, for in the public
No,
public
it's,
sy-
you
okay,
probably.
so in the public system, public healthcare system, for the universal healthcare provides free treatment to especially the poor, lower income people. So as the professor said, like when it's too much of demand and if it's like universal healthcare, free everything, so the rate of utilization of the services in the public sector, that gets dispatched totally because of the long waiting lines and
You have some, I mean, for some things you have long lines, for some things not. So since Brazil is focusing a lot in primary care, so for primary care nowadays you don't have big lines because even like doctors come to your house with this program of the family health program. So when they have this,
Or the community agents.
the community agents,
Community
yeah,
health
yeah,
workers
yeah.
come to your house.
And then, no, but some doctors are part of this community agents. So
Yeah.
community agents can be doctors, can be nurses, can be a lot of things.
Yeah.
So
so that reduces the load on the
on the hospital. So less people now go to the hospital. He was saying about the emergency room. Less people rely on the hospitals nowadays. So you have a smaller demand, so less waiting times and less problems like that. So for example, my university had they had like 5 hospitals, but 2 main hospitals. One is the huge one. They had like 100,000 people a day visiting this hospital. It's massive. It's incredible. But they also had another hospital. It was just only focused on pediatrics and OBGYN. So for people who are having, so if you're in labor, You go to that one. It's less crowded, less chances of infection. So they're trying to create like smaller units to be able to take this high demand from this big hospitals and reduce these waiting lines. So of course, for some things, for some procedures, of course you have waiting lines. One of the things that it's problematic in Brazil for waiting lines is for diagnosis. So if you need a MRI or a CT and it's not an emergency, then you have to wait for a few months to get it. So the private sector is very strong in that sense. Hello, Dr. Becker.
Yeah, I'm having serious trouble here. I'm calling from my phone now.
Yeah,
So
the internet.
my internet is not working.
It's
And
one of the things I do not miss about São Paulo.
They work worse than the health system.
That's true. So we have a Russian student who now is American, and he wanted to ask you a question. I don't know if you can hear him. I can repeat.
Sure. Hello, Dr. Becker. My name is Karen.
Please ask. I will try to hear in the phone.
Keep loud.
Sure.
You'll see my earphone.
So I see a lot of similarities between the Brazilian health system to the Russian modern healthcare system. So I just wanted to know about the SUS. So everything is free, right? But is there like also a guaranteed package to the population that differs from state by state, or?
Yeah. I think what he means is that different states have offer different services.
Yes. Because in Russia there's like a federal guaranteed package.
Did you hear what it said?
States
Only
will
based on
have more
availability.
resources available. We'll have more care providers. We'll have better hospitals, rich areas, and poor areas will have low. That's the only difference.
There's no difference by state. By SUS, everything is included.
Okay.
There's no package like that. You were entitled to this, and this, and that.
But
Everything.
let's make something clear. If you're rich, even in the SUS, you have better care. Amartya Sen says,
Amartya Sen.
the problem of the rich is not lack of resources only, it's lack of connections.
The problem of the poor.
If you're rich, if you know a doctor who knows someone, you get through the line, you get first, you get better care, you get the consultation first, you get the surgery first. Because the offer of services is very, very much below the need of services. So we don't have we're not providing enough to meet the demands of the population, especially on the medium complexity and the high complex. So secondary and tertiary care, specialty care and hospital care is much below the need. So if you have connections, you get there first.